topics that we've been discussing was how your body responds to a decline or an increase in the blood pressure. If you remember, when you hear increase in blood pressure, remember the heart is the one who gonna be responding. Remember, high blood pressure is gonna be an increase in the load that the heart will be trying to pump the blood against. So whenever I have an increase in my systemic blood pressure, this tells me that the heart will have trouble pumping the blood out. So the heart is the one who will be responding to this increased blood pressure in order to reduce it back to normal. So if you remember, if a person has high blood pressure, the amount of blood returning back to the heart, called the venous return, is going to be increased. And if I have an increase in the venous return returning to my right atrium, this will cause stretch of the atrium, stimulating the cardiac muscle cells of the atrium to release a hormone that we called atrial natriuretic peptide. And if you remember when we discussed why did we call it atrial natriuretic peptide, remember atrial because we find out that it's produced from the atrium, and natriuretic means it's releasing sodium out in the urine, and its chemical structure is a protein. It's a polypeptide chain, so I call it a peptide. It's a small protein. Remember, atrial natriuretic peptide acts on 3 different target organs. The first target organ was the kidney, and to be more specific, the juxtaglomerular apparatus. If you remember, juxtaglomerular apparatus was a cluster of cells that would be present per nephron. So if I have 1 million nephrons per kidney, this means that I have 1 million juxtaglomerular apparatus per kidney, or a total of 2 million. If you remember, juxtaglomerular apparatus did have 3 different types of cells: granular cells, macula densa, and the extraglomerular mesangial cells. The ones that responds to low blood pressure and would be stimulated because they act as mechanoreceptors, those are my granular cells. And this is the type of cells that the ANP is going to be acting on. If you remember, normally if I have a drop in my blood pressure, granular cells will detect this drop and will start to release renin. This is what normally happens if I have a decline in the blood pressure. And remember, renin is required for you to activate a plasma protein called angiotensinogen. Angiotensinogen is an inactive form of this hormone, and this will result in the formation of angiotensin II. Remember, activation of angiotensinogen, it's a 2-step process. First, I will be transforming angiotensinogen into angiotensin I, and then angiotensin I gets converted into angiotensin II. This is my active form. Remember, in order for me to convert angiotensin I into angiotensin II, I will need another enzyme called angiotensin converting enzyme. Angiotensin II, if you remember, did have multiple actions by which it will be able to increase your blood pressure. It did allow vasoconstriction, it allows the release of aldosterone and enhances the sodium reabsorption from the filtrate. It allows the release of ADH that will cause the retention of the water, preventing this water from being lost out in the urine. It also constricted the efferent arteriole and contracted the extraglomerular mesangial cells. Those are the 5 famous modes of action of angiotensin II by which it will increase your blood pressure. So if I don't have here under the effect of ANP, what's going to happen? ANP acts on the granular cells, preventing them from releasing renin. If I don't have renin, would I be able to convert angiotensinogen into angiotensin I? No. And if I don't have angiotensin I, would I get angiotensin II? What do you think? No. So angiotensin II, remember the very first and most important action here for angiotensin. That's why I called it angiotensin. Angio means blood vessel and tensin means tension. I'm causing vasoconstriction of the arterioles. So if I don't have angiotensin II that causes the constriction of the arterioles, what's going to happen? I will have vasodilation of my arterioles. Vasodilation of the arterioles. And remember, the 3 major factors that will affect the mean arterial pressure or my blood pressure, they were the cardiac output, the amount of blood that I pump from each ventricle per minute, and the resistance applied by the arterioles, and this is what we've called the total peripheral resistance. If I dilated the arterioles, what's going to happen to the resistance? Remember, I have a drop in my total peripheral resistance, and as a result, I will have a drop in my mean arterial pressure, and this is what I want. Remember, what is your main purpose here of atrial natriuretic peptide? Will be to respond to an increase in the blood pressure. So when you inhibit the release of renin, you don't get angiotensin II, you dilate the arterioles, dropping the total peripheral resistance, and as a result, you're going to have a drop in the mean arterial pressure. This is what you want. The second target organ that the ANP is going to be acting on, if you remember, this was the hypothalamus and the posterior pituitary gland. Remember, the hypothalamus nerve cells are going to be releasing a hormone that gets stored and released out from the posterior pituitary gland. We call this hormone is my anti-diuretic hormone, or ADH. Remember, ADH did do what? It retains the water that is about to get released out in the urine from the collecting ducts. So remember, ADH acts on the collecting ducts by stimulating those tubular cells to form aquaporine channels. And this will allow the water, rather than being released out in the urine, to be reabsorbed back into my blood. And this is what causes the formation of concentrated urine. So here, the urine is going to become concentrated as a result of the presence of ADH. So under the effect of ANP, atrial natriuretic peptide, what's going to happen? ANP targets the hypothalamus and posterior pituitary gland, inhibiting them from releasing ADH. And if I inhibit the release of ADH, what's going to happen? I will not be reabsorbing this water. And this water gets released out. So instead of having concentrated urine, I will have dilute urine. So I have extra amount of water that gets released out in the urine. But on the other hand, in the blood, remember, if you're not retaining the water, this water is being released out in the urine, you're gonna have a drop in your blood volume. And if I have a drop in my blood volume, how is this gonna affect my blood pressure? Remember, drop in your blood volume gonna cause a drop in your blood pressure. And this is what you want. A third target organ for ANP was the adrenal cortex. You remember, a pyramidal shaped gland located above your kidneys called the adrenal gland, and the adrenal gland is formed of an outer part called the cortex and an inner part called the medulla. If you remember, the adrenal cortex releases multiple hormones. The one that we're concerned with is called the aldosterone. If you remember, what was the normal action of aldosterone? If this is my nephron like this, I did have Bowman's capsule, proximal convoluted tubules, loop of Henle, and the distal convoluted tubules, and finally my collecting ducts. If you remember, the sodium gets reabsorbed normally. Around 65% of it in the proximal convoluted tubules, and the ascending limb of the loop of Henle, you're going to be reabsorbing 25%. So 65% gets reabsorbed in the proximal convoluted tubules, 25% would be reabsorbed in my ascending limb of the loop of Henle. Aldosterone, if present, it's going to be reabsorbing back the remaining 10% of the sodium to your blood from the distal convoluted tubules and from the collecting ducts. This is the function here of aldosterone. So 10%, only 10% of the sodium is under hormonal control. 90% of the sodium gonna get reabsorbed anyways, whether you do have aldosterone or not. Aldosterone reabsorbs this remaining 10% from the filtrate in the distal convoluted tubules and collecting ducts. So what's gonna be the effect here of aldosterone? I am putting sodium back to my blood. So what's gonna happen to my blood? This sodium gonna be followed by water. So normally, what is the effect of aldosterone? Aldosterone gonna be increasing your blood volume, and as a result, you're gonna have an increase in the blood pressure. So here, what's gonna be the effect of ANP? This is what we're discussing right now. ANP inhibits the release of aldosterone from the adrenal cortex. It inhibits the release of aldosterone. So if I inhibit the release of aldosterone, rather than retaining this 10% of sodium, this 10% of the sodium gonna be released out in the urine and will be followed by water. So 10% of the sodium, putting water with them, will be released out in the urine. So what's gonna happen to my blood volume if I'm not retaining this amount of fluid? This will result in a drop in my blood volume. And what's gonna this results in terms of blood pressure? If I have a drop in my blood volume, this means I would have a drop in my blood pressure, decrease in my blood pressure. Exactly. All right, so this is briefly how your body responds to what again? To an increase in blood pressure. So again, how do you respond? You've got increase in the venous return, you stretch the atria. Atrium will respond by releasing atrial natriuretic peptides that targets juxtaglomerular apparatus, hypothalamus and posterior pituitary gland, and the adrenal cortex. I inhibit all the three, inhibiting renin, inhibiting ADH, and inhibiting the release of aldosterone. The inhibition of all the three gonna result in a decrease in my blood pressure. All right, questions? All right, so what was the hormone, the main hormone that causes the retention of sodium again? What was the hormone that retains sodium? 10% of the sodium gonna be retained by which hormone, if present? Aldosterone. So I have other hormones that will be affecting the sodium retention. Two of them gonna be acting like the aldosterone. Those are the estrogens, female sex hormones, and the glucocorticoids. Both estrogens and glucocorticoids gonna cause an increase in the sodium reabsorption. And their presence gonna cause development of some degree of edema. So why corticosteroids and estrogens gonna have a similar action to the aldosterone? If you remember, those three hormones are released from the same place. Remember, where do you release the aldosterone from? It gets released from the adrenal cortex. But remember, the adrenal cortex did have three layers: zona glomerulosa, zona fasciculata, and zona reticularis, GFR. From outside in, it's going to be GFR, like glomerular filtration rate. All right, but here glomerulosa to the outside, fasciculata, and reticularis. If you remember, each of those layers is going to be producing a hormone. First one, glomerulosa, is going to be releasing aldosterone, which is the most famous mineralocorticoid. The zona fasciculata is going to be releasing glucocorticoids, like cortisone, cortisol, corticosterone, and the zona reticularis was releasing gonadocorticoids. Those are sex hormones, like the estrogens. So cortisol, aldosterone, and the estrogens share similar chemical structures. They have a very similar chemical structure. That's why there is some degree of overlap between their functions. All right, so estrogens will do what to the sodium? Will retain sodium. Cortisol also retains sodium. And this explains why some females will have during their menstrual cycles and during pregnancy some water retention causing ankle edema, so swelling in their ankle. So in a menstrual cycle, what happens? During the first 4 days of the cycle, I've got here the menstrual phase where I have the shedding of the endometrial lining and the blood flow. From day 4, around day 4, start to rebuild the endometrial lining, and this is going to be taking place under the effect of the estrogen that gets released from the ovary until the time of ovulation, which is around day 14 of the cycle. During the second half of the cycle, we're going to be producing a different ovarian hormone, which will take the upper hand, called progesterone. Progesterone, it's the hormone that precedes gestation. Pro before gestrone, it's gestation. Gestation means pregnancy. So each month, the body is going to be getting ready to have a pregnancy. So this hormone is the one that will be enhancing the glandular secretions of the endometrium, increasing the blood supply, because I'm expecting a fertilized egg to be implanted in this endometrium. So the endometrium gets ready by the presence of the progesterone. So some females under the effect of estrogen in the first half, they will experience some degree of edema, swelling in their foot. And this edema goes away whenever they start to release progesterone. Why? Because progesterone is going to be reducing the sodium reabsorption. It actually blocks the effect of aldosterone, promoting sodium and water release out in the urine. So some females will experience some degree of edema. Remember, edema starts with E. It's under the effect of estrogen. And it goes away when ovulation takes place and the ovary starts to produce progesterone instead. So the progesterone gets this water and sodium out of the body, reducing the formed edema during the second half of the cycle. Same takes place during pregnancy where I have very high estrogen levels. Questions? So again, estrogen as well as the glucocorticoids can have similar effect on the sodium reabsorption like the aldosterone. Remember, the three are released from the same gland. Progesterone, remember, it's going to be blocking the effect of aldosterone and reverses the edema that gets formed during the first half of the menstrual cycle. Moving on to the next solute that we're concerned with its regulation, it's going to be the calcium. Calcium is highly important for you to have a normal neuromuscular excitability. Also, as we're going to be discussing in details in the next chapter, it plays a very important role in the blood clot formation or the blood coagulation. Also, it's really important to maintain normal levels of blood calcium in order for you to be able to regulate the cell membrane permeability and to have normal secretory activities. If a person has a drop in his blood calcium level, we call this as hypocalcemia. Calcium, emia, blood, and hypo means low. If I have a drop in my blood calcium level, this will cause an increase in the excitability of the nerves and muscles will be so excited, so they will be performing a continuous contraction. So they are kept contracted. We call the continuous contraction of the skeletal muscles, it's a tetanic contraction. Having any high blood calcium level, this is what we call hypercalcemia. And in this case, the calcium is going to be competing with other important ions like the sodium, causing the inhibition of the neurons and muscle cells, and this will result in heart arrhythmias. Remember, one of the major functions of the calcium was to regulate the action potential of the cardiac muscle cells. Remember, in the cardiac muscle cells, I have a depolarization phase in which I'm allowing the sodium in, and I have a repolarization phase. First part of it, this is going to be due to the closure of the sodium. Next part of it, this is going to be a plateau phase where I have a stable membrane voltage, during which I have opened the potassium channel. So the potassium is going to be traveling to the inside, to the outside of the cells. And in order for me to prolong the time needed for me to repolarize, and in the same time to prolong the time when I'm able to refill and relax, what did we do? We opened calcium channels. And remember, the calcium influx did allow me to equalize the voltage, although I am losing positively charged ions to the outside, which are the potassium ions. So if I have hypercalcemia, what's going to happen? You're going to have a lot of calcium that will be traveling in, causing more prolongation in the plateau phase. So the heart, instead of contracting and then take enough time to relax, it will have a prolonged relaxation phase. So it might be missing the next beat, because the next signal that comes from the SA node will find the cardiac muscle cell still repolarizing, so it won't affect it. It won't cause its depolarization. So what's going to happen, rather than having a normal rhythm like this, I will be missing this beat, and this results in arrhythmia. Missing beats, I will have an irregular heart rate. All right, so arrhythmia, I've lost the normal rhythm of the heart. Calcium balance is controlled by a hormone release from 4 tiny glands located in the on the dorsal aspect of the thyroid gland. Remember this gland located in the front of your trachea. On its dorsal surface, we have 4 tiny little glands, We call them the parathyroid glands. Parathyroid glands are releasing a hormone called PTH or parathyroid hormone. PTH is going to be responsible to increase the blood calcium level. How PTH is going to be increasing my blood calcium level? It has three main actions. First one, it stimulates the bone-eating cells in your bones because those are my osteoclasts. They will be breaking down my bones, and this will cause the release of the calcium out in the blood to increase the blood calcium level. A second action of PTH will be by acting on the small intestines. Remember, in order for you to absorb calcium, you need active vitamin D. So the PTH action is going to be to activate vitamin D, which will allow you to enhance the absorption of the calcium from the foods that you're eating. And as you increase the absorption of calcium, the blood calcium level is going to go up. Does it make any sense for you to release calcium out of in the urine if you already have low blood calcium levels that you are trying to increase? Does it make any sense to release calcium out in the urine? No. So if I've got calcium that is traveling out in the filtrate and it's on its way to be released out in the urine, what would you like to do with this calcium that is about to get released in the urine? I want it back to my blood because I'm actually breaking down my bones to increase the blood calcium level. So I don't want any calcium to be released out in the urine. So what will I do here as PTH? PTH acts on my proximal convoluted tubules, enhancing the calcium reabsorption back to my blood. So three main actions on here of the PTH, parathyroid hormone. First one is resorption of the bones, breaking down the bone, enhancing the absorption by activating vitamin D, and a third action is going to be by activating the tubular cells of the distal convoluted tubules to enhance the calcium reabsorption. So three main actions on here: absorption, reabsorption, and resorption. Those are my three actions by which the PTH is going to be increasing your blood calcium level. So again, PTH activates here my osteoclasts, and this is going to cause the bone breakdown, releasing the calcium out in the blood. Second action for PTH would be to act on the kidney tubules, enhancing calcium reabsorption. And again, which part of the kidney tubules am I acting on? Which part is going to be hormonally controlled? It's going to be my distal convoluted tubules. Third action on here for PTH will be to enhance the activation of vitamin D in the kidneys. Activated vitamin D is going to be allowing you to enhance the calcium absorption in your small intestines. So three main actions again for PTH would be resorption of the bonds, reabsorption of the calcium in the kidney tubules, and enhance the absorption by activating vitamin D in the kidney, and the absorption is going to be taking place in the small intestine under the effect of the activated vitamin D. Questions? Questions? All right, so for the first in-class activity for today, what hormone is released when blood pressure is too high? If I have a high blood pressure, what is the hormones that you're going to be releasing? Is it renin, atrial natriuretic peptide, angiotensin 2, or aldosterone? Any other? Remember, who hates high blood pressure is your heart. So which one is released from the heart? Atrial natriuretic peptide. Atrial natriuretic peptide is going to be the hormone that gets released from the atrium to reduce the blood pressure. Moving on to another electrolyte. It's not an ion, but it's going to be an acid and base. If you remember by definition, what's an acid? An acid, it's a proton donor. What do I mean by a proton donor? I am a chemical that when dissociates in water, like the hydrochloric acid down here, I will be forming a hydrogen ion or a proton. Why do I call the hydrogen ion a proton? Remember, a hydrogen is formed of one proton and one electron. This is the hydrogen. So what is meant by being an ion? This means that this hydrogen has lost its electron. So what is still remaining of this hydrogen is just a proton. So hydrogen ion is a proton, just one proton. So again, what do I mean by an acid? An acid is a proton donor. And what do I mean by a base? Base is a proton acceptor. What do I mean by this? That when it dissociates in water, right here, sodium bicarbonate. Looking here, when it dissociates in water, it's going to be forming a hydroxyl group that is willing to bind to a proton to form water. So we call this is a proton acceptor. A proton acceptor. Why? Because the hydroxyl group is willing to bind to a proton in order to form water. So by definition, a base is a proton acceptor. If you remember, in order to check the degree of acidity or alkalinity of a substance, we check its pH. What is pH? This is the negative log of the hydrogen concentration or the proton concentration in a substance. When we measure the one of water, which is, see on here, water is both a proton acceptor and a proton donor. Both together is water. So pH of water is neutral. When we check the pH, we find out that it's equal to 7. So what is meant by a pH of 7? It's a neutral pH. It's neither an acid or a base. Remember, acids will have a pH less than 7. And bases will have a pH greater than 7. How about my blood? Blood is slightly alkalinic. It's 7.4. This is your blood pH. The normal range of your blood pH is 7.35 to 7.45. So if a person has a blood pH less than 7.35, does this person have more acids or more alkalis than what he needs? What do you think? If I have a pH, my normal pH is 7.4. If I have a pH less than 7.35, I'm going down. If I'm going down, I have more acids or more bases than what I need. What do you think? More acids. What do you think? Any other? If you're going down again, it's an acid or a base? Below 7, it's acid, right? So if my blood pH is going down, this means I have more acids or more bases than what I need. If you added base, will it get your blood pH up or down? If you add a base, will you move blood pH up or down? If you add bases, what do you think? Up or down? If you add a base, it's going to be pulling the blood pH up. But if you have acids, it will reduce the blood pH, go in it, and it's going to drop it below 7.35. So if I have a blood pH of 7.35 or less, this means I have extra acids in my blood. So we call this as acids in the blood, emia. Acidemia. What I mean by this, I have acids in the emia. I have extra acids in my blood. What if I have a blood pH greater than 7.45? This means I have more bases, more alkalis, or more acids in my blood than what I need. What do you think? Base. I have more base. 7 up, 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 it's a base. So I have more alkalis. So we call this as and alkali, enzyemia, alkalemia. So again, if I have extra acids in the blood, acidemia. If I have extra alkalis in the blood, it's alkalemia. Again, acidemia is going to be diagnosed if a person has a blood pH below 7.35. Alkalemia, if I have a blood pH greater than 7.45. Other names that we give for acidemia and alkalemia, which are more commonly used, are going to be acidosis and alkalosis. So again, if a person has a blood pH less than 7.35, he has acidosis. If a person has a blood pH greater than 7.45, it's an alkalosis. So how the body is capable to maintain this normal range for the blood pH? I have three lines of defense here that maintains normal blood pH. First one is going to be through chemical buffers. I have chemicals that are ready to react to reduce the alkalis, to reduce the acids whenever they increase their normal ranges. So they are here present in my blood, ready to respond, ready to react, like the proteins, like the bicarbonate buffer system. Those are proteins already existing in your blood. They will react automatically whenever you have an increase or a decrease in your blood pH. Those are called, again, my chemical buffer system. Another way by which you're going to be responding to a variation in your blood pH is going to be by activating or depressing your respiratory centers in the brainstem. And those are slower to react, but they have a much greater capacity to handle greater changes in the blood pH compared to the chemical buffers. A third line of defense that I have in order for me to maintain a normal blood pH within the 7.35 to 7.45 is going to be through the renal mechanisms. And this is going to be the most potent, but it requires hours to days in order to have an effect on the blood pH. All right, so those are the most potent, but they are slow to react. So you can't just handle major changes using chemical buffers, although they are rapid, but they have you have limited resources of those chemicals that you're going to need to react with the acids and bases. Starting with the chemical buffers, I have three types of buffers. I have the bicarbonate buffer system, I have the phosphate buffer system, and the protein buffer system. What we're focusing on right now is the bicarbonate buffer system, just to give you an impression about how the buffer system is going to be working. So if I have something like the hydrochloric acid added to my system, in my body, I have weak base ready to respond. And this weak base in the bicarbonate system is going to be something like as sodium bicarbonate. So what's going to happen if you add an acid to a base? An acid this potent is not going to be neutralized by a weak base like the sodium bicarbonate, but it's going to be transformed into a weaker acid, which is the carbonic acid here in this case, and a neutral salt. This is neutral. It's not a proton donor, it's not a proton acceptor, it's neutral. So what happened in here? Did I get rid of all the acids? What do you think? Did you completely get rid of all the acids? No, you still have an acid, but it's a weaker acid. So why you can't rely just on the chemical buffers? Because you see on here, you need to have enough resources of weak base, and you actually are not getting rid of all acids. You're still gonna have acids. So if you've got a large amount of strong acids that are added to your system, what's gonna happen? You're gonna be depleting the sodium bicarbonate, and you are not actually getting rid of all the acids. You're still gonna have some acids remaining. So you still gonna have to find another way to respond to this major change in the blood pH. You cannot just rely on the chemical buffer. What if I have alkalosis? I have a strong base added to my system. You have in your system weak acid ready to respond. When I add the strong base to the weak acid from my body, what will I do? I will get a weaker base I will get a weaker base and water, which is neutral. So the same concept on here. Did I get rid of all bases that I have? Did I get rid of all the bases that I have, all the alkalis that I'm faced with? No, you still have some base. So you cannot simply rely on the chemical buffer in order for you to maintain normal blood pH. The second mechanism by which you're going to be regulating your blood pH is going to be your respiratory system. Something to understand in order for you to understand the concept of how the respiration is going to be regulating your blood pH. Remember, carbon dioxide, when present in your blood, is going to be diluted in the water. It gets attached to the water, forming carbonic acid. So carbon dioxide in your blood is going to be circulating as an acid. So if you have lots of acids, what would you like to do? Would you like to breathe faster or to breathe slower? If I have lots of acids and I'm telling you that carbon dioxide in your blood, it's going to be mixed with water to form carbonic acid, which is an acid. Would you like to breathe faster or slower if you have acidosis? What do you think? If I have acidosis, I have lots of acids. I have lots of acids. Would you like me to breathe faster or slower? Slower. Slower. What else? Anyone? Slower. What do you think? Faster? So 3 slower, 1 faster so far. Normal. It's not a trick question. It's not a trick question. So don't expect to be normal. It's either faster or slower. So you've got now 3 fast, 3 slower, 2 faster. What do you think? If you have acidosis, would you like to breathe faster or slower? Slower, faster. All right, so carbon dioxide in your blood is an acid. So if I'm breathing faster, what's going to happen to the carbon dioxide? I'm washing out the carbon dioxide. If you get rid of the carbon dioxide, you're getting rid of what? You're getting rid of an acid. So acidosis will do what to my respiratory centers in my brain stem? It will be stimulating your respiratory centers for you to breathe faster. Why do you need to breathe faster? To get rid of what? To get rid of carbon dioxide. And when you get rid of carbon dioxide, you get rid of what? You get rid of carbonic acid. You get rid of acids. All right, so again, if a person has acidosis, would he be breathing faster and deeper or slower? Again, faster. So acidosis will do what to the respiratory rate? It will be increasing my respiratory rate. What if a person has alkalosis? What do you think? Would you like him to breathe faster or slower? Would you like to increase the respiratory rate or decrease the respiratory rate? Remember, alkalis, those are proton acceptors. So what would you like to do? Carbon dioxide in your blood, it's an acid. It's a proton donor. So if you have alkalosis, would you like to increase the carbon dioxide or decrease the carbon dioxide levels? What do you think? So I'm asking a different question now. Would you like to increase carbon dioxide or decrease carbon dioxide? 1 or 2? Increase carbon dioxide or decrease carbon dioxide? 1 or 2? 1, increase. 2, decrease. Right? Any other idea? Would you like to increase or decrease? If a person has alkalosis, would you like to increase carbon dioxide or decrease carbon dioxide in the blood? Anyone else? If you have alkalosis, would you like to increase carbon dioxide levels in the blood or decrease carbon dioxide levels in the blood? If you have alkalosis, you want to increase carbon dioxide levels. And how would I increase carbon dioxide levels in the blood? By breathing faster or slower? So if you want to get rid of the carbon dioxide, you will do what? You will breathe faster. I wash out carbon dioxide. You breathe faster, you get rid of more carbon dioxide. So if you want to retain carbon dioxide, if you want to increase carbon dioxide levels, you will depress respiration. You're going to be reducing the respiratory rate. So you're going to be breathing slower. So what's going to be the effect on here of alkalosis? It depresses the respiratory centers. And when you depress the respiratory center, this gonna cause carbon dioxide retention. And when you increase carbon dioxide in your blood, you are increasing what? You are increasing an acid. Remember, carbon dioxide in your blood is an acid. You breathe faster, you get rid of carbon dioxide. This means you get rid of an acid. You breathe slower, slow down the respiratory rate. What's going to happen? You build up carbon dioxide, you increase, I'm sorry, if you are breathing slower, you're going to be building up the carbon dioxide, increasing the acids in your system to equalize the alkali. What if I have acidosis? I have lots of acids. So what will I do? I will be breathing faster. And when I breathe faster, I get rid of more carbon dioxide. And when I get rid of carbon dioxide, what am I getting rid of as well? Acids. Carbon dioxide in your blood is an acid. Is this any questions? Any questions? Is this concept clear? All right. Renal mechanisms of acid-base balance. Renal regulation of acid-base balance depends mainly on the secretion of protons or hydrogen ions. Hydrogen secretion is taking place in proximal convoluted tubule, but please change this to distal convoluted tubules in your notes. Please change this into distal convoluted tubules, not proximal convoluted tubules. It's taking place in the distal convoluted tubules mainly, to a much less extent in the proximal, but mainly in my distal convoluted tubules and my collecting ducts. All right. So remember, what is the normal blood pH? Normal blood pH is between 7.35 to 7.45. If I have blood pH lower than 7.35, it's called acidosis. If I have a blood pH greater than 7.45, this is going to be alkalosis. So we classify the acidosis and alkalosis according to the reason behind this disturbance in the blood pH. If the reason is related to breathing, this will be classified as respiratory acidosis or respiratory alkalosis. If the reason is anything other than the respiration, kidney, for example, ingestion of toxins, anything else other than respiratory, it's going to be considered metabolic. So it might be metabolic acidosis or metabolic alkalosis. So again, we classify acidosis and alkalosis according to the reason behind the disturbance in the blood pH into either respiratory or metabolic. So I'll give you some examples on here. All right, so please answer those as part of your in-class activity for today. So second question for today, person who has a blood pH 7.3, or let's say 7.2. With chronic renal disease. Blood pH of 7.55, and this is caused due to lung fibrosis. Person came to the hospital with a blood pH of 7.55 due to ingestion of antacids. Blood pH of 7.25 due to ingestion of large amounts of alcohol. Number 4, ingestion of antacids. All right, so I want you to tell me for each one of those patients, what's going to be the diagnosis? Is this respiratory, metabolic, and is this acidosis or alkalosis? So starting with number 2, blood pH of 7.2. What do you think? Is it acidosis or alkalosis first? Is this acidosis or alkalosis? Acidosis. Is this a metabolic or respiratory acidosis? So number 2 is exactly metabolic acidosis. How about number 3? What do you think? All right, so here I want to change this here. Lung fibrosis, 7.25 as well. 7.25 due to lung fibrosis. What is your diagnosis on here? Respiratory acidosis. How about number 4? Number 4, patient was 7.55 and he ingested large amounts of antacids. What do you think? metabolic alkalosis. And last one in here, 7.25, ingestion of alcohol. Metabolic acidosis. Exactly. So pH imbalance, not caused by abnormal blood CO2 levels, it's going to be considered metabolic acidosis or alkalosis. If I have normal carbon dioxide levels, this means the respiratory system doesn't have anything to do with that. It's going to be considered metabolic. Causes of metabolic acidosis: ingestion of too much alcohol, acetic acid. So I'm adding acid to my system. So the amount of acids exceeds what I need. So I develop acidosis, not related to the lungs. Or I've lost large amounts of base, bicarbonate, like having severe diarrhea, persistent diarrhea. Having diarrhea all the time, I'm losing bicarb, which is a base. So I'm losing lots of base. So who's taking the upper hand? If you're losing base, alkalis, acids will take the upper hand. Accumulation of lactic acid in shock, ketosis, like keto acids, like in diabetic crisis, starvation, and kidney failure. All those can result in accumulation of acids and metabolic acidosis. So how diabetes and starvation can cause metabolic acidosis? It is something that we're going to be discussing in details when we get to the metabolism chapter. But just generally speaking, an overview of the concept on here. What is the problem with diabetes? Diabetes, I don't either have insulin or I don't have normal receptors for insulin. So what would I end up with? I will end up with having glucose present in the blood, but it's not able to get into my cells. So my cells cannot generate ATP energy from this glucose. This glucose remains outside in the blood, high blood glucose levels, but the cells, they are not able to produce energy because they didn't get the glucose inside to break it down. So what would I do here as a cell? I want to generate ATP to carry on my metabolic activities. So what will I do? I will start to break down fats. And when I break down fat to generate my ATP, there will be steps in the fat metabolism that requires actually you to have carbs in order to facilitate the breakdown of the fat. We're gonna know the details later on. But as I'm not able to get any carbs in the cell in order to break down the fat, so I'm not even able to break down the fat to generate the energy. So the other way for this fat is to form ketone bodies or keto acids. And as those keto acids start to accumulate in the system, this might result in metabolic acidosis. And that's why, if you did hear about a diet called Atkins diet, anybody here did hear about Atkins diet? Yes. And keto diet? Of course. The same concept on here. So what would they ask you to do? Not eat any carbs. And if you don't eat any carbs, what's going to happen? Your body will start to break down fat to generate energy. And this fat actually won't produce the energy because it requires you to have carbs in order to produce energy. So you're not producing energy, so this fat can't go back to be stored. So you can't store fat if you don't have energy. If I don't have energy, I will keep breaking down fat, but at a certain point, this fat will stop. And what's going to happen? It's going to be transformed into keto acids. And those keto acids, if they build up in large amounts, this puts the person at risk of developing metabolic acidosis. Currently, strict Atkins is not used. Currently, strict Atkins diet, which is a carb-free diet, it's not used. So if you go to any grocery store today, you will see Atkins meals and bars. Those are not actually Atkins. They still have some carbs because they know that if you don't get any carbs at all, what's going to happen? You put yourself at risk of developing metabolic acidosis. It's the same concept with starvation. If I'm starving, I'm not getting the carbs into my cells. And if I'm not getting the carbs into the cells, I will keep breaking down the fat. But if I don't have carbs, I can't even keep breaking down fat. There will be a point where I can't generate energy from the fat. So this fat can't be stored because you still need energy and can be broken down to produce ATP. So the third pathway for this fat is to be transformed into keto acids. And that's why diabetic patients, so especially type 1 diabetic patients, might develop diabetic ketoacidosis. Diabetic ketoacidosis is a type of metabolic acidosis. Clear, clear? Questions, questions? Any questions? All right, so metabolic acidosis is the most common imbalance of the blood pH. Comes next is going to be the metabolic alkalosis, which is much less common. It's going to be indicated by having a rise in the blood pH and in the carbon dioxide level in the blood. So the carbon dioxide is the one who is causing the drop in the carbon dioxide levels. The drop here in the carbon dioxide levels is the reason why, sorry, here, metabolic alkalosis. If I'm looking at the carbon dioxide levels, it will not be affected in this diagnosis. Why? Because again, the reason is not related to my breathing. So carbon dioxide levels, it's not gonna be affected. I have normal carbon dioxide levels. It's a metabolic disease. All right, so what might cause metabolic alkalosis? If a person has excessive vomiting, persistent vomiting, so what will happen? I am losing lots of acids, hydrochloric acid from my system. So if you keep losing acids who's going to take the upper hand right now? It's the alkalis. So develop alkalosis instead. Or if I have excessive intake of antacids, base. So a person has, for example, a gastric ulcer, so he has pain all the time in his stomach, so he decides to ingest lots of antacids to reduce the pain. So he might be at risk of developing metabolic alkalosis. What happens if blood pH drops below 7? This is going to cause depression of the CNS, causing coma and death. And pH above 7.8, this can cause excitation of the nervous system, which results in muscle tetany, extreme nervousness, convulsions, respiratory arrest, and death. So if a person has pH below 7, he is at the risk of dying. And if a person has a blood pH greater than 7.8, again, he is at risk of dying